Hi, this is Elliot Fishman, and welcome to our latest podcast. This is going to be on the challenges in the diagnosis of transitional cell carcinoma of the kidney, how we can optimize lesion detection, some of the pitfalls, and really try to show you a lot of cases. Now, this lecture is based on an outstanding exhibit that was at RSNA last year from our team at Hopkins, and so I want to give everybody credit. So let's get started. Some of the teaching points. The majority of urothelial carcinomas, also called transitional cell carcinomas, develop in the bladder, upper urinary tract of the kidney, and ureter, and they are challenging, particularly because they're small when they're early, when you can make a major difference in diagnosis. They also can mimic other pathologies, not necessarily tumors. They can really simulate inflammatory disease, so maybe they're not investigated as much as they should be. CT urography is the mainstay imaging modality, and that's what we're going to focus on today. But technique is critical. Multiplanar reconstructions, MIP, and volume rendering images are very helpful. MPR is mandatory, particularly coronal plane. The appearance of the upper tract has a wide range of variations. Again, small tumors to larger tumors, filling defects to calyceal amputation, to mass effects looking just like a hypovascular renal cell carcinoma. And again, this confusion to other tumors as well as inflammatory disease can make it a real challenge. And again, early detection leads to better outcomes, and you really need to be paying attention when you're doing the CT scans. Now, the number of cases under 2 per 100,000 population, upper tract, about 7% of urothelial tumors. The renal pelvis is the second most common site after the bladder. One thing about transitional cell carcinoma, they're often multifocal. And so you need to really be looking carefully. If you're happy you picked up a lesion in the kidney, look carefully at the bladder. If you pick up a lesion in the bladder, look carefully at the kidney and the ureter. Metachronous tumors are very, very common. There are some risk factors people talk about: smoking, alcohol, certain occupational carcinogens, and medication toxicity. Most of the cases are found incidentally, but patients present with hematuria or flank pain or obstructive symptoms. Typically, it's in older patients and up to 3 times more common in men than in women. 85% are papillary type, often slow growing, and about 15% are solid, which are more aggressive and higher stage at presentation. Now, when you suspect a lesion on CT, patients will be getting ureteroscopy for biopsy. Staging is critical. Spread goes locally to nodes earliest, but then can go the usual places any tumor of the kidney can go, to liver, to lung. Kidney-sparing surgery in low-risk disease, occasionally. Now remember, partial nephrectomies is what we do with most renal cancers. With TCC, often because they're infiltrative, it's much more difficult. We talk about low-risk upper tract tumors versus high-risk. Low-risk, under 2 cm, unifocal, low-grade cytology, and no invasive features on the CT, while high-risk, any of the following: over 2 cm, multifocal, hydronephrosis, high-grade cytology, and potentially a history of radical cystectomy, which means you're talking about multifocal disease. The ACR appropriateness criteria and the AUA guidelines, again, represent the key organizations that deal with kidney disease, and all of them recommend that CT be done. Ideally, maximize distension and opacification of the collecting system. Delayed phase imaging, I typically like at about 5 minutes. If you start going longer, people do 8 or 10 minutes, you have a lot of beam hardening, and you can hide tumors or overcall tumors. You want to be very, very careful. And when done correctly, CT has a very high sensitivity and very high specificity. Obviously, the smaller the lesion, the more difficult it is to diagnose. Now, we talk about the different phases. If I'm going to look at hematuria, we do a 4-phase study. We do non-contrast, then we do arterial, venous, and delayed phase imaging. Now, as I mentioned, delayed phase imaging is probably the single most important phase for looking for urothelial tumors, but if they're large enough, you'll pick them up early and they'll cause perfusion changes. People talk about split bolus. We never use split bolus. We like single bolus for everything we do. Dual energy and photon counting may be helpful, though there is really no proof to that at the current time. So what do? We do a single bolus, typically 100 to 100 ml of Omni 350, 5 cc's a second. Now, obviously, we do a non-contrast first through the kidneys. Then we do arterial from diaphragm to symphysis. Then we typically, in older patients, do venous from the kidneys through the pelvis, and then excretory phase from the diaphragm down to the pelvis. That works out very, very nicely. You can see the split bolus technique. You can do split bolus, but again, one of the challenges is every article on split bolus always said they're not really sure how accurate it is, and I just really have never used it, and I think our protocol works the best. We mentioned about post-processing, 3D post-processing with MIP, 3D post-processing with cinematic rendering can be very helpful. We are putting a lot of effort into cinematic rendering. It's a way of picking up potentially smaller tumors, not only in the kidney, but the liver, the pancreas, also to classify them. We are trying to improve the speed of cinematic rendering. That is having a lot of preset values, so you don't need to spend a lot of time. I could do a cinematic rendering of a kidney in multiple phases in well under 5 minutes. So it's not really that time intensive, but it does take more time, and all of us are very busy. I mentioned about pitfalls. Small tumors can be missed if the contrast is too dense, so don't wait 10 minutes for delayed phase. And also, when you look at the kidney, use a wider window. Don't do your usual 400 over 10, maybe do 550 over 50. You want to look through the dense contrast. When we do kidney studies, we typically use water as a contrast agent. We like to distend the bowel, the stomach. Also, you're hydrating the patient. We do not use positive contrast. We do not use diuretics. Remember, for a while, particularly the institutions in Boston, were recommending Lasix when you were doing CT of the kidneys. We don't do that. We don't do compression. We don't do prone position. We don't do log rolling. All of these things have come out over time, and they never really caught on. So let's see. If we're looking at the features, what are the classic things we're looking at? We're looking for urothelial thickening and enhancement. We're looking for focally dilated calyx. We're looking for an irregular or destroyed calyx, what's commonly referred to as an amputated calyx. We look for central solid masses in the renal pelvis, which can expand out, compress the sinus fat. Those are typically larger lesions. We also look for infiltrative hypodense lesions that look more like clear cell renal cell carcinomas. As I mentioned before, when these lesions, the TCCs, get larger, they can look just like a renal cell or lymphoma or metastasis, or can be confused with infection, including XGP or just almost any pyelonephritis. So again, you have to keep an open mind. The classic TCCs people always show in articles are easy to diagnose. It's some of the other ones I find that are more difficult and that are missed. And here's some examples, and I'm going to show you not quite 24 cases, but pretty close. Here's a nice example showing you the proximal ureter thickening. You can see it on the axial, you see it on the coronal. That's not under distension, that's infiltration. You can see on the second case the focal distal ureter thickening where the ureter is dilated above. Again, it's not that obvious on axial, but the MIP shows it nicely. And the third case with the upper pole where you can very nicely see that infiltration. Okay, really nice, but it is subtle, and unless you're careful, you can miss it. Here's a good example of looking at the renal pelvis. Sometimes we actually can pick up these masses on non-contrast scans. You can see the increased density. Sometimes blood clot can do that, non-opaque stones can do that, but you can see here the infiltration. And then, of course, when you get delayed phase imaging, the pelvis and the calyces are deformed, the ureter is involved. Very, very classic case of a high-grade urothelial tumor. Here's another example. Again, the coronal volume rendered view shows you the mass in the lower pole calyces. This could be in part blood clot, but this is really tumor extension coming down. Here it is again, very nicely shown. And in this case, there's an infiltrating tumor. You can see on the MIP imaging the distorted calyces better than you see it on the routine coronal. You could confuse this with a renal cell carcinoma, but once you see the calyces, I have to go with a TCC. Here's a nice example showing you the filling defect in the renal pelvis. That's the tumor. That's the tumor here on the cinematic rendering. And the patient also has disease with a tumor in the bladder. Again, the importance we talk about, look at everything, okay? Look very carefully. Here's another case. Infiltration of the patient's left renal pelvis. You can see there's some faint calcification on the non-contrast scan, which persists through the study. Occasionally, transitional cell carcinomas will have calcification. It's not that common, and you can see here very nicely the destruction of the calyces. You do want to look very carefully at the contralateral kidney, and I was a bit concerned, could there be something in the upper pole? But on additional imaging, I did not find anything, so it was a unilateral tumor. Another example, non-contrast mass in the renal pelvis. And then, of course, as you give contrast on the excretory phase imaging, the lesion is very well defined. The mass is about 2.5 centimeters, but this patient will need a nephrectomy because it's a large mass. There's no partial nephrectomy going to happen in this case. And again, you want to look very, very carefully. Another example, mass infiltrating the left renal pelvis. Again, the MIP is very helpful. You see the filling defect in the lower pole calyx, very nicely shown right there. And then as we keep going, here's a mass in the left renal pelvis with really central necrosis. This is a high-grade transitional cell, but I have to admit, when I read this case, to me it's an infiltrating tumor. I could think of lymphoma, but probably not. But I would think more of a renal cell carcinoma with infiltration. This is a great example of how aggressive transitional cell carcinomas could be. But again, it's that overlap. Could this be metastasis? That's a possibility as well. Another case, lobulated mass in the left renal pelvis. You can see it from the excretory phase. You can see the soft tissue mass on the arterial phase and coronal, and the cinematic rendering shows it very nicely as well. This ended up being on cytology a low-grade tumor, but there's no way I could tell that from looking at the CT scan. Here's another example, infiltration in the patient's right kidney. Again, if you said this is a renal cell carcinoma, if you said it's a clear cell, I would say no, because it's not that vascular. But he said papillary, I would agree. If you went for lymphoma, maybe, usually the kidneys are more infiltrated or they're larger, but it could be lymphoma. TCC is a good thought. So again, This case is easy in terms you have a renal tumor. I don't think you would be thinking about infection. You're thinking about tumor, but again, think about when you have infiltrating lesions, particularly when the focus, like this case, is the calyces, that you're dealing with a transitional cell carcinoma. Here's a couple more cases. Again, this infiltrating lesion in the patient's right kidney or infiltrating lesion in the left kidney. It's kind of funny, in the right kidney, pathology was a low-grade papillary tumor, while the image on your left, the tumor on path, was high-grade. I have to admit, the lower case, I would have looked at this and said this could be an infiltrating lymphoma. It's a really nice example for lymphoma. There's renal vein involvement. It can be a classic renal cell carcinoma, maybe a papillary type with infiltration, but these also were transitional cell carcinomas. So I'm showing you some examples of not the most typical appearance, but an appearance you need to be paying attention to. Now we talk about amputation. This is a really nice case. When you look at the left kidney, you notice that you're missing the calyces to the upper pole. When you look at the coronal, you can see the infiltration. So infiltrating mass, again, you could say, well, could this be lymphoma? But lymphoma usually displaces and doesn't amputate the calyces. When you give me calyceal amputation and infiltration, then I'm going with a transitional cell carcinoma, and that was the answer in this case. And just a couple more examples. You can see on your left an infiltrating tumor, and the patient had lung metastasis, and the imaging on your right, a similar case, infiltration, calyceal deformity, an aggressive transitional cell carcinoma. So I've now gone through a number of cases with you, actually more than 18 examples, from calyceal abnormalities to amputation, from infiltration to bulky tumors. Let's take a short break. I'll come back and show you a few more cases. I'll show you some pitfalls, and I'll show you some things that can be confused with transitional cell carcinoma. So let's say a 5-minute break and come right back. See you soon. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.